Okay, good morning,
Yeah, good morning.
teachers and colleagues. Okay, Dr. Atta, let me see how I can attempt the question.
Okay.
You've already read the question, so I think that this patient has snake bites with possible systemic envenomation. Now, and of course, complicated by AKI, acute kidney injury, because of the, of course, feature of reduced urine output. So that's my likely diagnosis. So other features that may be seen in snake envenomation include, okay, so maybe in the area where the patient has the bite, local leg swelling, there may be bleeding, there may also be ulceration. This patient may also have hematemesis and then stiff painful muzzle. This patient may also have excessive salivation, and of course the features of AKI like passage of including passage of dark colored urine. Now for the investigation, relevant investigation for this patient, I'm going to do the 20 minutes whole blood clotting time, and other investigations I also want to do for these patients include clotting profile, APTT and MPT, and of course NR. I'll go ahead and do serum arterial creatinine. Nothing that this patient does not have reduced urine output. I want to assess the functions of the kidney. I also do urinalysis, where there may also be hematuria or myoglobinuria in this patient. So these are the 5 investigations I will do. Okay, so possible complications from snake envenomation include 1, there may be local wound infection, and this may lead to extensive necrosis and gangrene. And of course, this may also lead to limb loss. Now, this patient may also have cardiac complications, and that's why ECG may also be a very important investigation to do, because they may have arrhythmias. Now, if this, depending on the snake, okay, if the snake maybe spits on the eyes of the patient, the patient may come down with blindness. The patient may have hematological complications like DIC. There may also be, of course, anaphylactic reaction from the antivenom we want to give, the patient. And there may also be paralysis of the respiratory muscle. So this patient may come down with respiratory failure. Then outline your management. Okay, for the principles of management of this patient, the management will be multidisciplinary. Okay, we want to do my ABC of resuscitation. I'll give this, as much as possible, I want to stabilize the patient, take quick history, to know if the patient will have an idea of the kind of snake. As much as possible, I want to relieve, I want to give them antivenom to this patient. Then I also want to give analgesic, maybe opioids, but I won't, as much as possible, I won't like to give aspirin or NSAIDs, because this would actually induce the coagulopathy. The wound care is important. Then as much as possible, give tetanus prophylaxis, and then identify and manage subsequent complications if they arise. I don't know, this is the extent I can attempt the question. Thank you.
Okay, yeah, thank you very much. That was a very good attempt. Thank you very much. So quickly, can we any contributions, any comments before we go to our next presenter? Any contributions, any comments? You can type in the chat box or you can raise your hand. So she just presented snake bite with envenomation. So any contribution to snake bite? So part of the management to be monitor the urine output, input, output too, because of the. Okay, so we also need to manage the acute kidney injury in these patients too, since part of the question was the patient had reduced urine output. Okay, let me go to the chat box. Okay, Dr. Momo says she didn't manage it here. Yes, we are managing it all here. So it's not her presentation per se. So management of AKI in this patient is very important. Fluid, you can give fluid, you can give blood as the case may be. And then you monitor the urine output. And as you give the anti-snake, and if patients response to them too, okay, it will also improve urinary output. Any other contributions? So, Dr. Sox, okay, not Dr. If we don't have, in the absence of any other contribution, Dr. Ekele, you can share this slide so that other people can. Okay, Dr. Ayodeji said wound debridement, she mentioned it, wound care, tetanus toxoid, she mentioned that. Okay, so we could give broad spectrum antibiotics. Okay. Dr. Regina, start sharing your slide while we are waiting for more contributions. The presenters today, are you in class today?
Good morning, sir. I'm here. I don't know if you can see my slides. I started sharing.
Okay. Yes, we are seeing.
Okay.
So you have 15 minutes for us to have this presentation, and then the next presenter should be ready, Dr. Ukamaka Daddy, Dr. Temilade, and Dr. Jamila Idris. Okay, you can go ahead.
Okay. Good morning, my teachers, senior colleagues, and colleagues. My name is Dr. Regina Weke, and I'll be taking a question 1B of the April 2022 General Medicine Practice question. So 1B says, below is the clinical photograph of a patient with sezary syndrome. What are the 3 diagnostic features of this disease? List 5 clinical features of this disease. How will you treat this patient? And question 4 is, what is the commonest cause of death in patients with this disease? So before we answer the questions, I would like to just introduce briefly what sezary syndrome is all about. Sezary syndrome is an aggressive leukemic variant. It's a type of cutaneous T-cell lymphoma, which is characterized by erythroderma, lymphadenopathy, and peripheral blood involvement. by the malignant sezary cells. This disease was described by Albert Sezary and Yves Boren in 1938. It's known to affect the elderly population more, with males being more affected than females in the ratio of 2:1, and the mean age is about 60 to 65 years. The incidence is said to be higher in whites compared to African Americans, and there is no genetic predisposition to this disease. The primary cutaneous lymphomas, according to WHO and EORTC, are classified into cutaneous T-cell lymphomas and cutaneous B-cell lymphomas. And the cutaneous T-cell lymphomas are known to represent approximately 70 to 82% of all primary cutaneous lymphomas. These cutaneous T-cell lymphomas are divided into indolent clinical behavior and those with aggressive subtypes. So for those with the aggressive subtypes, a typical example is the sezary syndrome, which we are discussing today. So the examples of the cutaneous T-cell lymphomas with indolent clinical behavior include mycosis fungoides, as well as other variants and subtypes of mycosis fungoides like folliculotropic mycosis, pegytoid reticulosis, and others. We also have primary cutaneous CD30 lymphoproliferative disorders and all. Then for those with aggressive clinical behavior, we have the sezary syndrome, adult T-cell leukemia, extranodal NK T-cell lymphomas, primary cutaneous acral CD8 T-cell lymphomas, among others. So to answer our questions, the question 1 says, what are the 3 diagnostic features of this disease? The 3 diagnostic features that are to be seen in order to make diagnosis of sezary syndrome include erythroderma, in which more than 80% of body surface area is usually affected. Then they also have a lymphadenopathy, as well as presence of a sezary cell count of greater or equals to 1,000 cells per microliter. Question 2 says, list 5 clinical features of this disease. So the clinical features include erythroderma, which we have mentioned, affecting more than 80% of body surface area. They have a diffuse erythema, which appears eczematous with variable scaling sizes and types. Patients might have itching. In some cases too, there might be preceding a history of mycosis fungoides infection. In the past, it was even agreed that mycosis fungoides is the same as sezary syndrome. But later, with events in research studies, it was found out that they are actually 2 different disease entities, but very close. Patients will also present with pruritus, which are said to be quite debilitating. There might also be cutaneous involvement, most times like palmoplantar keratoderma, alopecia, ectropion, and also dystrophic neck changes. Lymphadenopathy is also seen in these patients, and they might present with hepatosplenomegaly. So question 3 says, how will you treat this patient? The treatment of sezary syndrome is based on the burden of disease and the level of progression in terms of rapidness, because we are told that it's an aggressive, although rare disease, but with aggressive progression. So it is also important to know the stage of this disease. That's why it's also important to stage these patients when they come before commencement of treatment. It should also be noted that it is important to preserve the immune response in order to prevent infections. Use of immunomodulatory therapy before chemotherapy is also advocated for, and then combination therapy is preferred over monotherapy. So the available treatment options for management or treatment of sezary syndrome include the use of antineoplastic agents like chlorambucil, methotrexate, etoposide, and others. Then immunomodulators like interferon alpha 2b, monoclonal antibody antineoplastics like aletuzumab is also instituted in this patient depending on the stage of the disease. Topical skin products can also be used, like imiquimod 5% cream. Topical meclotramine can also be given. Retinoid-like agents are also, there's also place for the use of retinoid-like agents, corticosteroid like prednisolone. Patients may also benefit from extracorporeal photopheresis, ultraviolet therapy, and radiation therapy as well. So question 4 says, what is the commonest cause of death in patients with this disease? The commonest cause of death in patients with sezary syndrome is systemic infection, and it has been found, Staphylococcus aureus has been found to be notorious for this. Also, organisms like Pseudomonas aeruginosa. Other causes of death in these patients can also be secondary malignancies like higher grade of non-Hodgkin's lymphoma, Hodgkin's disease, colon cancer. Patients can also die from cardiopulmonary complications. So the brief pathophysiology of sezary syndrome. The pathogenesis is actually not well known, but a small percentage of cases are said to be associated with infection by human T lymphotropic viruses type 1 and 2, which are known to be endemic in southern Japan, the Caribbean islands, and part of the Middle East. The typical immunophenotype of abnormal T cell population in sezary syndrome are the presence of CD3 cells, CD4, CD7, CD26, CD8. These tumor cells are known to originate from memory T cells or skin homing CD4 T cells expressing cutaneous lymphocyte antigen and chemokine receptors CCR4 and CCR7. And patients with sezary syndrome are known to have suppressed immunity. This is as a result of the malignant cells because they produce type 2 T cells cytokines, which are known to suppress the type 1 immunity by decreasing the production of interleukin 12. And the role of the interleukin 12 is to stimulate production of interferon gamma and tumor necrosis factor, which are known to help protect against the tumors. So how do we make diagnosis? Like I mentioned in the question I answered, that diagnosis, however, diagnosis is made by the three symptoms that the patient must present with. However, there is need for good history taking and then physical examination, and then carry out some investigations in order to come up with the diagnosis of sezary syndrome. So from clinically examining the patient, they present with erythroderma, they have a generalized lymphadenopathy, the whole, you can see the palmoplantar keratosis, which they can have dystrophic nail changes, affectation of the eyes and all. Then for investigations, skin biopsy can be taken for histology, in which we will see overlying acanthosis, dermal fibrosis, atypical cerebriform nuclei of the cells, minimal epidermotrophism. For this epidermotrophism in sezary cells, they might be there, and even if they appear, it's quite minimal, unlike in mycosis fungoides, which is so similar to sezary syndrome, and they have more epidermotrophism. Then for immunohistochemistry, we see the presence of CD4 cells being affected. Then the lymph node biopsy of lymph node histology will show the effacement of a nodal architecture by these malignant sezary cells. The immunophenotyping it can be done using a flow cytometry of the peripheral blood, which will show the about at least 1,000 sezary cells per millimeter cube, CD4 CD8 ratio of greater than 10, CD4 CD7 ratio of greater than 30%, CD4 CD26 ratio of greater than 40%. Molecular studies. Here, high sequencing of the T cell receptor beta gene regions will show clonally related T cells in the skin, peripheral blood, and lymph nodes. Then peripheral blood film will show the atypical T lymphocytes with the cerebriform nuclei. Serum lactate dehydrogenase and uric acid also need to be assayed for, and in these patients, their levels are elevated, and they are known to be markers of aggressive disease. So chest radiograph is also important to look at if there is involvement of the lungs. Abdominopelvic computed tomography scan can also be done in patients in whom visceral involvement is being suspected. PET scanning can also be done to determine the visceral involvement as well. So for the staging of sezary disease, it's staged from, we have from stage 1A to stage 4B. For stage 1A disease, here patients present with patchy or plaque-like skin diseases involving less than 10% of the skin surface area. Then for stage 1B, they have patchy plaque-like skin diseases involving 10% or more of the skin surface area. For stage 2B disease, tumors are seen. In stage 3D disease, they have a generalized erythroderma. Then for stage 4A1, there's erythroderma with a significant blood involvement. For stage 4A2 disease, they have a lymph node biopsy is done, which shows a total effacement by these malignant sickle cells. Then for stage 4B disease, there is now visceral involvement, like perhaps the lung might be involved, the liver, as well as the bone marrows. So what are the complications of sezary syndrome? Generally, patients will have a decrease their quality of life. They will not be able to go about their daily activities because of the intense pruritus. They have itching, difficulty falling asleep, and this might tip them into anxiety and depression. There is also increased risk of secondary bacterial infection. This is as a result of the disruption in the skin barrier, and as well as patients are also immunocompromised. Then there can also be large cell transformation of these original malignant cells, like formation of larger lymphomas. Then patients might present with metastasis to the lungs, the liver, and other surrounding organs. So for the prognosis, poor prognostic factors for sezary syndrome includes age greater than 60 years of age presenting with this disease, and when you have males being affected, and if there is an advanced stage of the disease, like patient presenting at stage 4, then greater than 80% of body surface area being involved. When there is elevated lactate dehydrogenase, like I said, is a marker of aggressive disease. And then the median survival of sezary syndrome is estimated at 3 to 5 years, with a 5-year survival of less than 30%. Thank you.
Thank you, Dr. Regina, for a wonderful presentation. Okay, so the class is open for contributions, comments. You can type in. Okay. So Dr. Emeka said, can you explain preserved immune response to prevent infection?
Okay, so so for it's when in treatment, because we know that chemotherapeutic agents, like I said before, in the treatment, it's actually instituted in the management of this disease. However, when we use a chemotherapy, it tends to also bring down the immune system. So it's good to use some immunomodulators that will help to improve the body's the whole system to fight against cancer cells. So that's why immunomodulators are given, to improve the body's immune response, the activities of the antibodies in the body, in order to fight these cancer cells, and also to withstand any chemotherapeutic agents that might be given.
Okay, I don't know whether it's clear now. Can you go over it again?
Okay, sir. I said following the question that was asked
Yeah, he
to
was asking preserve immune response to prevent infection.
yes, that's to build the because they are predisposed because of the whole skin lesion and possible super bacterial infection because the body is already exposed. So it's good to give like immunomodulators to improve the body's fight against the infection. So to build up the immune system.
Okay. How common, Dr. Alozie say, how common is sezary syndrome in our environment? Dr. Yusuf said, can you explain what sezary cells are? Then Dr. Itohan said, what about kids? Are you using two devices?
Hello, sir. I can hear you. No, sir.
Okay, as if I'm echoing.
No.
Okay, so how common is sezary syndrome in our environment? What are sezary cells? What about PPE in your study? Okay, go ahead with this then.
Hello.
Yes.
Maybe it's network. Because I was going, so I think we just continue.
Hello, ma.
Can you hear me?
Yeah, I can hear you, but
We are all echoing. You are echoing.
There's a Regina way to use devices on. Regina.
Hello, sir. Sir. Hello.
Yes.
Hello. Can you hear me?
Yeah, I can hear you.
Okay. So for the first question, the first person asked if how common is it? But I said in the the opening statement is actually a very rare infection. I haven't seen one around here, but from the books, it's known to be very rare. So then, for the second question, I don't know.
What are sezary cells?
Okay, the sezary cells are the malignant cells, which are the T cells that are formed by the cancer cells, which proliferate and are seen actually when biopsy or the biopsy samples are collected and also histologically assayed. So they are malignant cells which proliferate from the malignant T cells actually.
Okay.
Dr. Regina is asking you the characteristics of the cells. I'm sure you came across it. Yes.
Yeah, the cells appear cerebriform. The nuclei of these cells appear cerebriform, and they can be seen in blood films or from the biopsy specimens, and they appear because it's an aggressive disease. They appear for you to make diagnosis. They have to go to like greater or equals to 1,000 cells per microliter.
There, one more thing, Dr. Regina. Is there any picture of the sezary cells in your presentation in your study?
Okay, I didn't put it, ma. Maybe after the
Okay.
presentation, because I saw when I was reading around it, I saw the cells, how they appear convoluted or cerebriform.
Because sometimes in the exams they don't show you picture, so that the participants, once they see similar pictures, they know this is sezary cells. You understand? So thank you so much. Thank you.
Thank you.
Okay, yeah. So Dr. Itohan is talking about stage 2A, since you didn't say anything about it. And Dr. Ifoma, he said, did you come across the most common nail manifestation of sezary syndrome?
Sorry, sir. The most common nail involvement.
Nail manifestation of sezary syndrome.
Okay, I saw. Yeah, they have a dystrophic nail changes like onychomycosis. That's and some other. I can't remember, but onychomycosis is one of them that was mentioned, and some other ones.
Dr.
Okay.
Regina, be careful of the words you use, you know. You are being recorded.
Okay, too.
Onychomycosis is a fungal, you know, is specific for fungal nail infection. So it's best to just say dystrophic nail changes.
Okay,
Yes,
ma'am.
dystrophic nail changes is better.
Okay. What of stage 2A?
Mm, okay, sir. So, but for the staging, okay. Stage one. I think I'm sorry. I will check and arrange the staging, but I didn't really get the stage 2A because I think there should be stage 2A, but I didn't really get. I will check and correct it in the slide.
Okay.
Mm.
Dr. Ekera is saying, please, are there known risk factors? What stage can this patient be placed in? Are there differentials for this condition?
Okay. Okay. Well, the for causes of sezary syndrome, there are no known causes. However, it's known that there are some risk factors that can predispose people to acquiring this disease, like infections, viral infection, bacterial or fungal infections, exposure to occupational exposures, environmental factors have also been in some few studies, not so large. And then human papillomavirus infections have also been noted somewhere, as well as HIV infections can predispose, but they are not real. But the causes, or like etiology, is not known.
Okay.
Then
What
for
stage?
the stage for our patient, is it from the picture on the question?
Okay, well, you don't have the picture, so you wouldn't. The pictures is not there, but the clinical scenario.
Yes. For this patient, because I think the patient that is presented here, like this picture from the question here, there is a palmoplantar involvement. So there was no clinical scenario. Actually, picture was only shown, and with the palmoplantar involvement, I feel this patient will be at about stage 2 because there is involvement of both the palms and the sole of the feet. These are the only 2 pictures, but there was no clinical scenario. I don't know if there are already visceral involvement. If there is.
All right. Differentials.
Hello, sir.
Yes, I can hear you.
Okay. I didn't get what you said, sir.
Okay, she was asking for differentials too.
Okay. Well, differential majorly skin infections, any erythrodermic, like no one major differential is mycosis fungoides, and other cutaneous T-cell lymphoma, Hodgkin's lymphoma can also be a differential, and some erythrodermic skin diseases can actually go for differential Sézary syndrome.
Okay, so Dr. Japaro is asking, well, how a follow-up question: differentiate sezary from mycosis from fungoides and the second one is it cutaneous erythema or erythroderma? Are they the same? And then he mentioned the third triad. He knows that the third triad is atypical mononuclear cells, that the sezary cells in
Yes, sir.
peripheral blood cells in 10 to 15%.
Okay, well, sir, for the first question, he said I should to differentiate. Like I said, mycosis fungoides and the sezary cell syndrome are both primary cutaneous T-cell lymphoma. However, for the differentiation of these two diseases is based on the gene mutation, the genes that are found in the cells. These cells, they have there are the the gene mutations for these diseases are different. Like in Sézary syndrome, they can code for CD, CD27. There are some I can't remember, but the differences are based on the gene that are being expressed. They are different. They have different genes. Then, for in skin, when you do a skin biopsy for Sézary syndrome, the so for in Sézary syndrome, the mucosal involvement of the, like I said, they can have epidermal proliferation, which is more in mycosis fungoides are more than in Sézary cell syndrome. And then in appearance, for mycosis fungoides, the thin lesions appear to be flat and patchy, unlike in Sézary, where there might be skin eruptions and more the ailments or the skin infections are more raised. These are the two differences. And the next question, what's the next question, sir?
Cutaneous erythema or erythroderma, are they the same?
Well, they have erythroderma. Not only they are not really the same, because for the erythroderma it's more intense than just the cutaneous erythema. So I think that.
Okay.
So what we have in Sézary syndrome is the erythroderma.
Okay. So supportive treatment with antihistamine is important. Then regular moisturization, the cirrhosis, arthritis. Dr. Momodu posted how the Sezary cells look like, and then staging, the stage 2, it was brought out. Then erythrodermic psoriasis can be a differential
Yes, sir. Okay.
dress syndrome. So those are the comments. Dr. Esther, you want to say something? Please, Dr. Regina, can you unshare your slides so that the next sharing their slides?
Yes, sir.
Good morning. Good morning, our teacher. Good morning, Dr. Ata. Good morning, Dr. Regina. Thank you so much for the detailed presentation. I think she has said a lot and she has responded to so many things. I just want to say a few things to start with. I think from her opening statement, it is a very rare disease. And it's also important to know that it's very distressing and debilitating to patients. So it's very important when we're managing them to keep that in mind. Just to comment on a few things for us to remember, if you want to remember the clinical features from head to toe, from alopecia, mucinosa to the down, palmoplantar keratoderma. So virtually every system is affected. So just take it from the head to toe and then go that way, and then you have clinical feature almost everywhere in the scalp, alopecia, mucinosa, we have ectropium in the eyes. Of course, we have the lymphadenopathy, peripheral lymphadenopathy, which is generalized. She talked about chest symptoms. On the nails, yes, we talked about, so the most common nail features are nail dystrophy, which are various changes, can be paronychia, onycholysis. And then the most specific changes are actually anonychia, onychochisia, and then nail thickening. So those are the things that are specific. Other things on the, okay, I think she commented about the differences. So mycosis fungoides is the most common of the cutaneous lymphomas, and about 5 to 10% are said to progress to sezary syndrome, which was also known as, or is known as the leukemic phase. However, it's important to also take note that sezary syndrome can occur de novo without the patient having a mycosis fungoides. So if it's a progression, it will be very difficult to differentiate. But like she said, in differentiation, the lymphocytes have epidermotrophism. The lymphocytes have epidermotrophism, and then there's initially in the patch stage, what they have is psoriasiform dermatitis. So initially, when they present early, when you do the biopsy, actually most of them are misdiagnosed as psoriasis. So it may also be a reason why we don't see so many of them, because at that stage, you just see psoriasiform hyperplasia. You may not see the other key things in psoriasis, but then subsequently you may need to repeat the biopsies to see the other features. Like she mentioned, the cerebriform nuclei, and then with basophilic cytoplasm, and they also can have hypersegmented neutrophils. Also, so in addition to treatment, like I mentioned, if you've seen a patient with Sézary syndrome, it can actually be very distressing for them. The first point she made in terms of not sleeping because of the pruritus, they don't have just pruritus, they also have paresthesias. So the paresthesias are so debilitating that affects their quality of life. And I think for most of them, that's even their problem more than the erythroderma or the variable dermatitis that they have. So it's important to add to our management. It's multidisciplinary. Sorry, we need to mention that, because we don't manage the patients alone. The hematologists, the psychiatrists or psychologists also play a role. Also, in addition to the treatment, nitrogen mustard is also used. Then I wanted to mention something again on yeah, so the differentials, this acronym we use to remember. So all other causes of erythroderma can be differentials, which we use the acronym SCARP ID. So S for seborrheic dermatitis, even though the other differences will now come in terms of the pruritus, the erythroderma they have. So, but these ones also have erythroderma. Generally, the involvement of the skin beyond 80%, like she said, or some will use the word exfoliative dermatitis. So we have S, scalp dermatitis, seborrheic dermatitis, C for contact dermatitis, A for atopic dermatitis with widespread lesions that are obvious. Then the L is now the cutaneous lymphoma, so which the Sézary syndrome is. And then the P is for the erythrodermic psoriasis, pityriasis rubra pilaris, which is also a very, very close differentials. The only difference here, we have islands of sparing, but they also have palmoplantar keratoderma, and then the erythrodermic involvement. Then the I is for idiopathic, and then D for drugs. Key among them is vancomycin, which is known for the red man syndrome. So I think she has done very well, and she has said so much. Thank you.
Yeah, thank you, Dr. Esther, for the wonderful dermatology touch to the presentation. All right. Any other contribution? Can the next presenter, Dr. Edadi, are you in class? Any other presenter? Can you start sharing your slides?
Yes,
So that
yes, yeah. Good morning, I'm in class. Yes, I'm around.
Can I quickly share the slide? Dr. Christopher, is there any, and our teachers, any other contribution while we wait for?
The presenters of Dr. Regina and Dr. Esther, thank you so much, Dr. Esther. You made my job so easy. Thank you so much. Thank you. There's been nothing to add between these two people. There's been nothing to add. They've done well. They've done justice to the question. And I must also appreciate the participants that asked relevant questions, and not just relevant questions. Those are asked questions. Thank you. You highlighted some of the important points. So thank you so much. Thank you. That's from me.
Thank you, ma. Any other contribution from us? Okay, Dr. Daddy, you can put it on slide on PowerPoint. Sorry, yeah, on the slideshow, so that you can start with. Can you hear me?
Yes, good morning.
Go ahead. Yes.
Okay. Can you see my slide?
Yeah, we can see it.
Okay. Good morning, my teachers and colleagues. I'll be taking April 2022 practice question 2A, and it goes this way. A 27-year-old man weighs 127 kilograms with a height of 1.67 meters, developed exceptional dyspnea since 6 months ago, no cough, smoked 10 sticks per day of cigarette for 10 years, no known family history of diabetes, hypertension, lung cancer, or chronic obstructive pulmonary disease. Lung function tests showed a restrictive pattern. The questions are, what is the diagnosis? Number 2, what is the cause of these symptoms? Number 3, what tests will you do to evaluate him? And number 4, how will you manage the patient? I just decided to just do a brief summary of what the biodata and everything that was given. The patient is 27 years old, as a male, with a body mass index of 45.6 kilogram per meter square. And patient has a sessional dyspnea of 6 months duration, but no cough. At pack years, calculated by number of packs per day, patient smokes 10 sticks and have 0.5 packs per day, multiplied by 10, that is about 5 pack years. No family history of diabetics, hypertension, lung cancer, and chronic obstructive pulmonary disease. The patient has lung function tests that showed restrictive pattern. So the first is saying, what is the diagnosis? In view of the fact that what the diagnosis is obesity, basically obesity hypoventilation syndrome. Patient has, but however, obesity hypoventilation syndrome is actually a diagnosis of exclusion, even though some other questions were not asked. So I would like to find out. I would like to also know obstructive sleep apnea syndrome. But then I would have loved to be sure about, to ask them about history of loud snoring, if it was obstructive sleep apnea syndrome, daytime slow somnolence, poor sleep quality, early morning headache, decreased libido, or reduced this. Well, it could also, I also would have loved to rule out idiopathic pulmonary fibrosis, because this patient came with a sessional dyspnea and then this restrictive pattern of lung function. So I also rule out that, but in this case, patient has no cough, has idiopathic pulmonary fibrosis will have come with dry cough, with malaria, weight loss, arthritis, and then if you on the examination will have cyanosis, finger clubbing, and then other interstitial lung disease. I will have asked history of occupational exposure, drugs, history of use of drugs, infection, maybe coming in form of fever. So having excluded this, I will have, I think patient has obesity hypoventilation syndrome. Number 2, what is the cause of this symptom? Yeah, obviously the patient with a body mass index of 45.6 kilogram per meter square. The major cause of this symptom it will likely be morbid obesity that the patient has, because every other thing is okay. Apart, it has restrictive pattern. There's no cough, no long COPD, non diabetics, no history of hypertension. So there is no other possible cause of this. So I think the cause of this symptom will be morbid obesity. I just decided to just look at classify obesity based on weight body mass index. I'm looking at underweight with normal distance using obesity. Once is body mass index is 30 and above is obesity. So now it's either whether it is class 1, class 2, or class 3. In this case, patient has extreme obesity, that is class 4. Patient's body mass index is above is about 45.6 kilogram per meter square. Number 3 question was, what test would you like to evaluate him? Patient has already done lung function test, but the first thing I would have loved to do is arterial blood gas analysis. It's said to be the most definitive diagnostic test for demonstration of daytime hypoventilation. So in that case, we're looking at hypercapnia, patient coming with increased partial pressure of carbon dioxide and then low partial pressure of oxygenized hypoxia. So that would patient. Then I would also like to do polysonography, but in this case, just to exclude obstructive sleep apnea syndrome, because it is known to obesity hypoventilation syndrome is known to coexist with obstructive sleep apnea for in 90% of cases. And of course, out of that 90% of cases, you also have 70% of them coming with severe obstructive sleep apnea syndrome. So they coexist. It's just like a spectrum. So I would like to be sure that it's obstructive sleep obesity hypoventilation syndrome. Like I said, it's the diagnosis of exclusion. So I need to do that overnight polysonography to exclude obstructive sleep apnea syndrome. So then spirometry, which has been done in this case to show restrictive pattern. If you do forced expiratory volume in 1 second over forced vital capacity, it will either be normal or increase. So it's a restrictive pattern. Then I'll just do pulse oximetry. If the partial pressure of oxygen on room air is less than 94%, of course I'll see that yes, it's obstructive. It's a pointer to the fact that it's obstructive obesity hypoventilation syndrome. Then I will do electrolyte urea creatinine, but in this case, electrolyte is my main focus. I mean, is the bicarbonate. If bicarbonate level is greater than 127 milliequivalent per liter, I will hold on to obesity, and then the patient is obese. I will also hold on to obesity hypoventilation syndrome. The percent of total sleep time with partial pressure of oxygen below 90% can be useful in a sonographic variable for the evaluation of course, I've said that before. They also like to do fasting lipid profiles in view of the fact that this patient is having obesity. Of course, if you know the definition of obesity, it's a syndrome that has a lot of components, dyslipidemia, hypertension. So there are a lot of things involved that cause a lot of. There are so many problems with obesity. So I would like to rule out dyslipidemia. I would love to do full blood fasting blood glucose. But in this case, in this particular patient does not have the patient. I've been told that patient does not have diabetes. And then I'd like to do serum uric acid, which may be increased in the setting of obesity, full blood count, autoimmune antibody. I've said that obesity hypoventilation syndrome is a diagnosis of exclusion. So I like to also do this to exclude other possible causes of gestational dyspnea, fetish syndrome, that is in the case of another other interstitial lung diseases. Then fasting serum leptin level. Serum leptin has been said to be implicated in the pathogenesis of obesity hypoventilation syndrome. Serotonin resistance has been shown to be a major one of the mechanisms that will result in obesity, hypoventilation syndrome. So I would like to do that. In this case, it will be increased. Thyroid function test, hypothyroidism. I will also exclude hypothyroidism in the patient with reduced with gestational dyspnea and to ensure that it's not due to hypothyroidism. So thyroid function test to rule out hypothyroidism. I'll do test X-ray to rule out idiopathic pulmonary fibrosis, other intestinal lung disease. I will do ECG to rule out. Of course, one of the major complications of obesity hypoventilation syndrome is pulmonary hypertension. So of course, ECG will show me patterns in pulmonary hypertension and sinus tachycardia, features of right ventricular hypertrophy. That will also show in the case of if I do echocardiography using transthoracic echocardiography in particular. Then I'll do Epworth sleepiness score, of course, to rule out obstructive sleep apnea syndrome. I've already said that it's a diagnosis of exclusion. How will you manage this patient? Management of this patient involves multidisciplinary team approach. The physician, even the anesthetics, the surgeons, particularly the ENT surgeons and other members of the team, the pharmacists, the nurse. It's a multidisciplinary approach. The dietitian. So that everybody will be brought on board. Then I'll take detailed history and then do detailed physical examination because it's a diagnosis of exclusion. I need to exclude other possible causes of exertional dyspnea with restrictive pattern of lung function. So I must bring that. That's why from the beginning I said it's a diagnosis of exclusion. I must rule out obstructive sleep apnea syndrome, look at history of daytime sleepiness and somnolence and all that. The early morning headache, loud snoring. So that's when I take such history to exclude all other possible causes of such restrictive pattern of lung disease. And then ocular obstruction, that would guide me properly. Then the major management will be involve either using positive airway pressure. That will help to also to significantly reduce the nocturnal buildup of partial pressure of carbon dioxide and improve sleepiness during the daytime. That may be in the form of continuous positive airway pressure. That's the first line, particularly if there is no concomitant obstructive sleep apnea. If there's concomitant obstructive sleep apnea syndrome, I've said that in 90% of the cases you have obstructive sleep apnea syndrome coexisting with obesity hypoventilation syndrome. We can also use other modalities like a bi-level positive airway pressure and then other non-invasive ventilation modalities like particularly if the patient is stable and ambulatory, you can use the other non-invasive modalities. But key in this case, because the major culprit here is the obesity. So lifestyle modification ensure that patient is weight loss. You educate the patient on weight loss and then exercise, which could be aerobic and graded exercise. And weight loss is the key thing here to a reduction to significantly reduce carbon dioxide production and improve sleep apnea severity and alveolar ventilation. So that weight loss will also help to improve pulmonary artery hypertension and left ventricular dysfunction, significantly reducing cardiovascular compromise in this patient. So what are the therapeutic goals I would like to use in weight loss will require intervention using some drugs to take like statins, fibrates, orlistat, and then our GLP-1 agonists and other anti-diabetic agents that possibly can cause weight loss, like the liraglutide and metformin. Then if our target will be to produce about 20 to 25 to 30% of total body weight, to lose that, If that does not happen, then that's when we now think of surgery, the bariatric surgery, if there's no contraindication. Key thing, like our patient here, smoking cessation. Our patient smoked, though not quite significant, 10 sticks per day for 10 years, about has five backpack years. So I will advise that the patient cease smoking using I will adopt the 5 A's framework for smoking cessation. I ask, advise, assess, and arrange. And the use of nicotine replacement therapy. There are so many of them. And once in the course of trying to assess and advise patient and then assist, I will adopt these modalities to cause patient can cease smoking within looking at 30 days to 12 weeks approach. So if this is so severe, tracheostomy can also be done. But major thing here, another major thing that can also be done here is social support, psychosocial support. Get the patient in the course of using the 5 A's framework. You can also get the patient to know other people who have overcome cigarette smoking cessation, and then issue of obesity. Get the patient to support groups that who have overcome that, and that will also help the patient. Treatment of possible complications like even pulmonary hypertension, of course, with several agents like endothelin antagonist, bocetin, and ambristatin, and calcium channel blocker, the phosphodiesterase 5 inhibitors. If in the setting of a complication in pulmonary hypertension, when patient has developed right-sided heart failure with leg swelling and other, diuretics can be used. So I just want to look at a brief this one of obesity, hypoventilation syndrome. But hello,
can you hear me?
Yes, I'm hearing.
Okay. So this topic has been presented just a few days ago. So we'll just, and then our time is far spent. So we'll just take few contributions, and then you still post this presentation on the WhatsApp group so that anybody that wants to go through it, they can go through it at their own time. So we'll just take contributions. Okay, let me go to the chat box. Okay, Dr. Emeka says high resolution CT is better in ruling out interstitial lung disease rather than chest X-ray. Dr. Fabo Hinda said left ventricular dysfunction and pulmonary hypertension can also be differentials here. Dr. Olaleko said abdominal ultrasound can be done and LFT because obesity too cannot be associated with NAFLD, that's non-alcoholic fatty disease. Dr. Ekele said the AHI is greater than 5 per hour. Dr. Momodu said OHS with pulmonary hypertension, I think maybe the diagnosis. Dr. Esther says, can you kindly go over the role of leptin? The role of leptin. Okay, that's the first question. Just take notes. Okay. Dr. Ekele said we should also consider other complications of obesity other than OHS. Okay, Dr. Momodu. It's also to help quit with the 5 A's. You can motivate to quit with 5 hours too. Okay, yeah. I think you can go ahead with the role of leptin. I think that is the only question here. The role of leptin. I think Dr. Momodu too also had helped us, just a few days ago in terms of management, emphasizing more on lifestyle, modifications. So, okay, just answer the leptin role before Dr. Temitope comes in.
Okay, yeah. Thank you very much. Are you hearing me?
Yes, we can hear you.
Okay, yeah. Leptin is actually about 16 kilodalton. It's a hormone that actually a local hormone produced by the adipocyte. adipocyte. What it does is actually to try to increase, stimulate ventilation by acting on the hypothalamus, part of the hypothalamus, trying to see increase, of course, apart from, in this case, in the setting of ventilation, it stimulates ventilation, but it also helps to suppress what they call it, suppress appetite. But in the case, or in this setting, is ventilation. But in as long as the thing tries to take care of the hypercapnia, the chronic hypercapnia, and all that, there seems to be a blunted chemo sensitivity in the setting of hypoventilation syndrome. Also, as much as leptin level is increased, trying to see how to normalize the chronic hypocapnia. More because it's chronic, more of the hypocapnia, like in this setting, you have 6 months, is produced. So there seems to be resistance. So in this case, it's leptin resistance that will now result in obesity. Because even though leptin tries to compensate, try to stimulate the hypothalamus and all that to try to see that there is so much ventilation, increase in ventilation, but it's not happening in the setting of hypoventilation syndrome. There is blunted chemosensitivity in this case.
Okay, Dr. Temisope, make your contribution.
Okay. Thank you good morning, everyone. Thank you very much for the lovely presentation. I just wanted to emphasize that, so for all patients with OHS, they have a form of sleep-related breathing disorder. Therefore, the mainstay of treatment is actually positive airway pressure therapy. Yes, there's weight loss and lifestyle modifications, but if the patient is not placed on a form of positive airway pressure therapy, then the treatment has not commenced. So about 80 to 90% of them will have a coexisting OSA, where about 10% will have a central sleep apnea. So all of them have a sleep-related breathing disorder. So most times, the first line PAP therapy that's usually started is the CPAP, since the majority of them will have OSA. And then in those, whatever type of sleep related breathing disorder they have would have been diagnosed during the polysomnogram. So for those that have more of a central sleep apnea, then can be started on non-invasive ventilation that has various modes. So I just wanted to emphasize and that this PAP therapy has to be commenced before, even while the patient is trying to lose weight. You would not wait and then wait for the patient to try to lose weight. And the weight loss program has to be supervised and controlled. So it's not that we want them to rapidly lose weight. So it's going to take some time. It's going to take some months or possibly years for them to go down to their ideal weight, because most of these patients are about 50% above their ideal weight. So it will be unhealthy for them to rapidly lose weight. And in some of them, bariatric surgery may be helpful, but even for patients to go for bariatric surgery, they actually have to be on a structured program first, which even after the bariatric surgery, they would continue with the diet and physical rehabilitation, the exercises to sustain the weight loss. So, but apart from that, it is important that in the management of OHS, the patient is placed on a positive airway pressure therapy. Thank you.
All right, thank you. It's okay. Your contribution. So, is there any other contribution before we hand over to our teachers? Okay, Dr. Christabel, hand over to you.
Thank you, Dr. Asa. Hope I can be heard. Okay, thank you so much. I must commend the 3 speakers today. Thank you, Dr. Success, for coming